Very good morning to one and all. And today what I plan to do is I would talk on bridging the gap in postprandial control with insulin. Am I audible? Yeah. We cannot start any talk on insulin without paying our gratitude to Banting and Best. And it's not 101 year of insulin discovery. When insulin was discovered, the only aim was survival of type 1 diabetes. Over the years, our journey of learning insulin, new product, technology to assess the effectiveness of insulin, reaching to normal fasting PP2BS, normal 6-time blood sugar, and now normal 24-hour blood glucose monitoring based assessment and choosing right dose, right amount of insulin for base glucose management has come into the picture. Today, what I'm going to do is I'm going to talk we'll talk about what is the gap in our understanding by talking on physiological basis of postprandial glycemia and problem with excursion. Briefly talk about limitation of current insulin, clinical practice challenge, and then we'll talk about a solution strategy to address this gap. And I'm going to focus on innovative insulin, that is insulin analog, which are newer, which has come after 2017 onwards. I would not touch on adjunctive therapy or personalized diabetes management. And I must tell that patient education is very important, but I would end with 2 or 3 cases and would leave the last case to my next speaker to carry forward. So let's talk. We all know that PPG is obviously blood glucose following meal. It is influenced by timing of the meal, it's influenced by composition of meal, and efficacy of insulin, time of initiation of insulin action and duration of insulin action, peak of insulin action. PPG excursion can lead to oxidative stress on one side, can cause endothelial dysfunction, and in turn cause vascular injury and cardiovascular and microvascular risk factors. Effect. So when we talk about postprandial state, we used to measure PP2BS, but are we talking about it? No, once an individual has a meal, glucose level starts rising within 10 minutes. It normally reaches to peak by about 1 hour. Concentration returns to preprandial level by about 3 hours, but then carbohydrate absorption may persist for 5 to 6 hours, and this may change with people who have autonomic dysfunction and gastroparesis. Glycemic control throughout this postprandial state is very important. Your insulin should start working immediately and should have effect for 3 to 4 hours. So what is importance of PPG control? We also have to keep in mind our Indian context. We Indians take a lot of carbohydrate, and as a result of this, postprandial hypoglycemia is very important consideration in Indian patients. PPG contributes to all A1C from higher to lower in Asian patient, in fact, every diabetic patient. So if we achieve postprandial glucose early, our chances of achieving normal HbA1c comes early. Postprandial hypoglycemia is very strong risk factor, as we all know, on micro and macrovascular complication. So, effective treatment strategy for diabetes when we are thinking of insulin should aim at controlling not only fasting blood sugar, postprandial blood glucose, but also all throughout the day insulin, prevention of excursion post-meal. And now we have a gazette in our hand. Always get innovation into your practice, and that is using CGMS. That gives us the best idea. Early intervention to minimize PPG excursion may reduce cardiovascular risk factors, risk impacts. So if you look at insulin therapy in PPG control, remember the basal, your physiology days. We have basal insulin all through our days, and with meal, according to the carbohydrate content, the type of additional fibers into it, we have post-breakfast, lunch, and dinner-induced hyperglycemia. We have different insulins available with different level of, these are made by composition, by adding different the substance into it to lengthen the duration of action and to shorten the duration of action. And we have to choose the right insulin for right purpose. So where is the role of basal bolus? Today we are going to talk how to use insulin for postprandial sugar, and that means we consider that patient is already on basal insulin. When you talk about basal insulin, when we want a better control, we have basal plus therapy and basal bolus therapy. Basal plus is basal insulin, which controls your sugar, and one of the meal where sugars are really bad after meal, you add it. So that is basal bolus. Basal plus. Basal bolus is before every meal, besides basal insulin, you add insulin. So remember the difference between basal plus and basal bolus. We use basal bolus regime in all patients with type 1 diabetes. Unless they are on premix insulin, they are well controlled. But after CGMs, we are more convinced that giving basal bolus is best option if affordable and if available, and patient is educated and to enhance their knowledge of advantage of this type of sugar, they do comply. Thanks to a lot of pharmaceutical who helps, and a lot of foundations like Baroda has Diabetic Association of Baroda, Mother Foundation, lot of states have this kind of, who gives free insulin to people. So you can always take help of them to assist them for better quality of insulin of a choice if they required. In type 2 diabetes mellitus, basal alone may be good enough with OHA. And with newer drugs, DPP-4 inhibitor, SGLT2 inhibitor, and GLP-1 receptor antagonist, you can do the job. Many individuals with type 2 diabetes requires additional insulin before meal if their postprandial is not under control for best glycemic control. Hypoglycemia management in non-critical care setting is also important, so is in ICU. And these two places, basal bolus plays a very important role. We know different kind of insulin, and to this august audience, I don't need to talk more about it. But then look at it. Till we were using Actrapid, human insulin, there was regular human insulin. Before that, we were using porcine and bovine insulin. Those days are gone. In fact, we don't find those insulin now. Then came era where we had rapid insulin, acting insulin like Aspart, Lispro, Glucilin. And now we have days where we have ultra rapid acting insulin like Fias by Novo and Lumjiv by Cipla. We are looking forward for inhaled human insulin, which would help avoiding injection pricks, not looking at the cost. It's sometimes facility that matters. So when we talk about physiological insulin secretion, our basal bolus mimics that pattern of endogenous insulin production in an individual. Basal insulin suppresses glucose production between meal and overnight, and it requires about 40 to 50% of total dose. And bolus insulin is mealtime, which limit hyperglycemia after meals. Intermediate rise and sharp peak after 1 hour, and 10 to 20% of total insulin requirement at each meal. Remember our old gold Actrapid and human insulin, the effect lasted for a little longer time. And so we had problem of post-absorptive hypoglycemia, 4, 5, 6, 7 hour patient, if don't take meal at around 4, after taking meal after 4, 5 hours, if they don't take small snack, then hypoglycemia. So like that was a problem with that insulin. Then came rapid insulin, acting insulin. We have Novo Rapid, we have Lispro. We have, so like these are insulin which is fairly comfortable range that we want. But somewhere we want more finesse. And one more important concept is inter-meal interval. When that patient compromises, we need something which acts faster. So prandial insulin, what are the quality of ideal prandial insulin? It should match physiological control. It should have fast absorption, rapid onset, and short duration of action. It should mimic endogenous insulin secretion and match insulin absorption and action to food-related rise, post-prandial, post-glucose. Talking about rapid-acting insulin, developed to increase insulin absorption and have faster onset of action as compared to regular human insulin, and it provides optimal PPG control with that. But what is a fallacy? I talked to you. Onset of action does not match carbohydrate absorption, resulting in limited postprandial glucose control. And PKPD also does not mimic physiological phenomena. So, expert recommended in India regarding the choice of prandial insulin. This expert committee gathering occurred in 2018, and now they are planning one in this year. Chawla had headed these, and they said regular active insulin preferred over regular human, rapid-acting insulin is preferred over rapid human insulin. Ultra-fast-acting insulin more closely mimic physiological mealtime insulin, and ultra-fast-acting insulin is better suited to Indian population who have high carbohydrate intake and who have higher postprandial hypoglycemia. This is a concept you must remember is injection meal interval. Timing of meal insulin in patients less than 26 years were studied in a cohort. And you'll be surprised, 80% of patients did not maintain the injection meal interval. It's only 21% took it several minutes before meal. And this was done in about 5,000 patients of type 1 diabetes who was on regular interval. So something that bothered them the most was injection meal interval. And we have to do something to improve their compliance by reducing this. And that is why there's a role of rapid-acting insulin. So key takeaway, in real-world setting, many patients may use either or no injection meal interval. Ultra-rapid-acting insulin with faster absorption, more rapid action of action, so they should be preferred, and they might reduce the need for the injection meal interval. So one should consider taking into the patient's preference. So here comes the role of education. You have to talk to patient. As compared to regular insulin, rapid-acting insulin is a little expensive, but the luxury that you get is this, that you don't have to wait. So you can take it immediately before meal. Ultra-rapid-acting insulin can be taken with meal or after meal, so that forgetfulness doesn't bother. Rushing to college, rushing to school, or rushing to office does not matter. Anyone who wants to walk into someone's consulting room can take it outside, eat something, and get inside. So that is very important. Next thing that I want to talk is, again, utilizing innovation in your practice, embrace it. And that is CGMS. There was time where we were measuring only urine sugar. From that, we went to blood sugar monitoring. We were doing fasting and PP2BAs. Then we started doing 5, 6, and 7 times finger prick sugar. And we started doing HbA1c. And we were happy with HbA1c. And there are a lot of correlation of HbA1c with micro and macrovascular complication. But then there's lack of information about acute glycemic excursion. It cannot detect time spent in hypoglycemia and hyperglycemia. Someone with HbA1c7 can have all throughout the day normal sugar, but can have sugar of 50 to 200, and still they can have normal HbA1c. It fails to identify magnitude and frequency of glucose variation, and measurement can be confounded in the situations like anemia, hemoglobinopathy, and pregnancy, and of course renal failure. So we don't do it in renal failure after one level. So time in range gives us idea of time CGMS gives us idea about time in range, time above range, and time below range. And yesterday we had a fantastic workshop on it. So I'm not going to go in detail. So expectation from new prandial insulin. Provide PPG reduction for entire postprandial period. Immediately after meal 10 minutes to 4 hours. Provide closest physiological glucose control, increase time in range, and ease patient burden, allowing dosing per most common pattern that we see it in our practice is no injection meal interval. And that's where we have ultra-rapid insulin. We have Fiasp from 2017. Now we have ultra-rapid insulin Lispro available to us. So this ultra-rapid insulin we have been using for a couple of years. This is a new product, so we talk about it. It's always nice to talk about new product and then start experiencing it and then utilizing it in a patient population. It's a novel insulin of Lispro. It is two addition into it. One is citrate and second is teprostylenil. Both of them have advantage. One increases local vasodilatation, other increases in vascular permeability. And that is why they have faster absorption. Onset of action was 20 minutes post-dose, 11 minutes faster than Lispro. During 30-minute post-dose, it had threefold greater glucose-lowering effect as compared to Lispro. It is modification of Lispro, nothing else. Maximum glucose-lowering effect occurred between 1 to 3 hours, the time when postprandial glycemia matters. Total glucose infused during the CLAMP study, glucose CLAMP study, to see the effectiveness of insulin was between these two were practically same. So if you look at pharmacokinetic of insulin absorption of NovoRapid, Humalog, Fiasp, and ultra-rapid Lispro, you see here, it is most near physiological effect. Early PPG profile of ultra-rapid Lispro most closely matched the glucose profile of healthy subject. It shows the lowest mean glucose excursion, and it has numerically greater glucose lowering effect. Do we have evidence? I mean, product has come, but do we have studies? Unless we have evidence-based medicine or efficacy, safety, better advantage, we would not take it. So there were two trials done, Pronto type 1D and Pronto type 2D. Obviously, Pronto type 2D was for type 2 diabetes, and Pronto type 1D was for type 1 diabetes. It was ultra-rapid Lispro versus Lispro in basal bolus regime in patient with type 2 diabetes mellitus. If you look at the graph, it shows that ultra-rapid Lispro was non-inferior to Lispro in change of A1C. So non-inferiority is accepted. After sitagliptin trial, we have accepted the word non-inferiority. If you look at PPG excursion during meal at 26 weeks in this kind of people, ultra-rapid Lispro showed significantly better control of postprandial glucose excursion as compared to Lispro. Safety, same, no changes in hypoglycemia. There was little higher hypoglycemia immediately in ultra-rapid insulin, but that probably one has to decide on taking little lower dose, so that take it in a positive way. Safety-wise, otherwise no changes. So there were no significant difference in clinically relevant category of hypoglycemia, including severe, documented, and nocturnal hypoglycemia, and safety profile and overall frequency were similar between the treatment groups. So what does it offer? 10-minute faster onset of action, duration shorter by 44 minutes, closely matches physiological glucose control seen in subjects, provides significant better control of PPG excursion, glycemia control without increasing risk of hypoglycemia 4th, 5th, 6th hour, and increased daytime time in range 44 minutes as compared to regular insulin. This is what all we wanted in one ideal insulin. Yes, there is a gap of little high sugar around 3rd, 4th hour, but then we can manage by adding more carbohydrate. Looking at Pronto type 1 diabetes, mealtime and post-meal ultra-rapid mealtime and post-meal, they compared both. Sometimes you don't know what child would eat. So we can use in future AI, that this is a platter given to child and this is what child took. So how much insulin can we give? And that can be given post-meal. This is going to be biggest advantage. Mealtime and post-meal ultra-rapid Lispro, non-inferior to Lispro of change in A1C. Better control of PPG excursion throughout PPG state from 15 minutes to 4 hours is seen with this product. Safety, good. So key takeaway, improvement in glycemic control were achieved without increasing risk of documented hypoglycemia, and it has similar incidence of side effect. Do I have to summarize? No, you knew everything. So I'll end with cases. Arjun, 30-year type 1 diabetes, on once daily glargine and basal ectrapid insulin. He travels, and he has concern of insulin meal interval and had occasional hypoglycemia at around 5, where his behavior with his colleagues were a little disturbed. He was getting agitated at time, and there was documented sugar of 60. His frequent postprandial glucose spikes up to 200, Action Plus, modify bolus insulin to rapid-acting insulin or ultra-rapid-acting insulin so that you avoid hypoglycemia and you have better postprandial control. Monitor glycemic level and titrate dose for best control. Neha, type 2 diabetes, BMI on higher side, 29. She's on once daily glargine with sitagliptin, metformin, and dapagliflozin. A1C is 8.7. Antenna, BMI is high. Would you increase basal insulin? You'll think of adding GLP-1. You'll review her whether she's type 2 diabetes who needs insulin or who does not need insulin. Add bolus or lifetime modification. And I would leave this answer in your practice to answer on your own. Don't be over-aggressive. Here probably GLP-1 would do the job, unless not. And I would leave with you with last case also, 65-year male, type 2 diabetes, hypertension, and CAD, admitted with community-acquired pneumonia requiring admission. His diet was unpredictable. RBS ranged from 240 to 300, and no multi-organ failure. Which insulin regime is recommended for this patient? Would you use sliding scale insulin? Hello? Will you use sliding scale insulin? It's absolute no, it's outdated. Basal bolus insulin regime, fantastic option. Continuous insulin infusion is required. Insulin pump you don't use in ICU. But I leave it to Parag to tackle this kind of cases in his practice. Which insulin if you use basal bolus? Regular human insulin, rapid acting, ultra rapid acting, or premix insulin. I hope my presentation gave you an answer here. Majority of you must be practicing it. If not, use innovation in your practice. Thank you so much.